Joel Topf. I'm here with Nephrology Times. We've got a roundtable. We're going to be talking about rare kidney disease. Specifically, we're going to be talking about immune complement mediated MPGN and C3 glomerulopathy. And we got a great panel here. We're just going to kind of go around the room and introduce ourselves.
Hi, I'm Cybele Ghossein. I'm a nephrologist at Northwestern, right here in Chicago.
Hi, I'm Suneel Udani. I'm a nephrologist in community practice at Nephrology Associates in Northern Illinois.
I'm Anthony Chang. I'm a renal pathologist at the University of Chicago.
My name is Fernando Fervenza. I'm a nephrologist at Mayo Clinic in Rochester, Minnesota, and I train under Dr. Rodby.
Roger Rodby. I'm a nephrologist at Rush University Medical Center, Chicago.
And so we're going to be talking about rare kidney diseases, but more specifically, we're going to be talking about C3 glomerulopathy and immune complex membranoproliferative GN. And, you know, to me, these are kind of, it's wild. These are diseases that didn't even exist, at least by this name, when we were, well, at least when I was in nephrology fellowship, looking at the average age of our roundtable, when all of us were in fellowship. Right? We've had to like kind of readapt and relearn these different diseases. And you just go back not that far long ago, you go back to 2021 when you look at the KDIGO-GN guidelines, and there really was not very much interesting to treat these. You know, you had mycophenolate mofetil, you had some steroids, you had some titoxan, and now we've got a couple of new drugs. So I just want to, why don't we kind of rewind all the way back to, can you guys remember 2024? You just don't have to go back to when there was not much there. And how were you approaching people with the C3GN, for example?
Well, you know, for me, I was just using the drugs that were out there that were just sort of generic drugs that we would use for immunological, renal diseases. So, MMF, you mentioned, steroids. Sometimes I would add some CNIs, so like tacrolimus or cyclosporin for proteinuria. There was really no targeted therapy.
Kind of the generic
exactly,
GN box.
Very generic GN box, yeah.
Right, and what kind of outcomes were you seeing with that?
You know, I think there's a whole spectrum of this disease, right? Some are much, are pretty mild, and so they'd go on for a while. But then there were some that were really very aggressive, and they would lose kidney function pretty rapidly. Yeah. So.
Does anybody else?
I think that highlights such an important point is that these diseases have been so heterogeneous for so long, and we get sort of reassured by this treatment response that really we don't really know what we're doing, and we didn't know.
When you say treatment response, what are you looking for?
Yeah, we would look for reduction of proteinuria as our sort of main outcome. We'd look for preservation of kidney function, and sometimes you would be able to see that trend over time, but we didn't oftentimes have that much time to see these folks. So it was we thought we were doing things the way they should be done, and we thought we may see an impact, but it was a lot of random outcomes.
I would like to emphasize what has been said, and the heterogeneity of the disease. Because for one side, and what always amazed me, because I said, well, to do a randomized study in this disease is going to be quite tricky. Because it's exactly as Dr. Ghossein just said, I remember seeing patients that say, well, how do you say they have been seen with C3GN for 20 years? And they say, excuse me, don't come with this business since the disease was only named about 10 years ago. How can you see a patient for 20 years? Well, for this easy reason is because the patient had a biopsy when age 11, and then we saw the patient 10 years later. And then by that time, we go and say, well, let's see the biopsy again. Let's look, and then you look and say, that was it. At that time, we didn't call C3GN. Then you know that indeed was a C3GN to begin. But 20 years later, the same patient had a creatinine of 0.8, all right, and a proteinuria of 500 milligrams, so no progression whatsoever, all right? So on the other hand, we will see patients that was diagnosed a year ago, and now come with a creatinine of 2.5 and has been treated with MMF, prednisone, and the disease is still progressing, and those patients a few months later will end on that. So this is an enormous spectrum of how the disease can, including patients with, Dr. Chang can tell you that they come with C3 and cancer, very aggressive way. So it's a spectrum. So why this variety? Well, we can go later, but what is true? We have this, not every C3GN is the same.
So I guess Tony, is there something on the pathology that we're missing? Can we kind of pick out this prognosis and kind of determine this clinical care from something that you're seeing?
Well, I mean, I think the extent of interstitial fibrosis tubular atrophy and scarring has always been, right, the best predictor.
This is the first disease where that's important.
Yeah, right.
And right, clearly that's been the, go-to for any disease. Other than that, I think we don't have a lot of guidance.
But that's all late. I mean, do you see anything?
Right,
Do you see
right.
anything prospectively?
No, and we don't get the
amount of
biopsies
complement,
typically.
or where or anything like that, or the amount of deposits, or where they are that you think could predict outcome?
It's a great question. I think we need to look at the intensity of C3 at the time of the biopsy. We need to try to correlate those things and see what the outcome is, right? If you have 2+ C3 versus 3+ C3 and all these other things that I'm not sure it's really being carefully analyzed. So
Fernando brought up a point. He said, this has only been around 10 years or something, whatever the number is. You wonder, where was it? How did we miss it? And part of it is because, it took forever to learn how to the nomenclature for MPGN based on pathophysiology as opposed to where the deposits were. When you think back that it was type 1, type 2, type 3, it's kind of absurd. And then it evolved, out of Mayo Clinic, a really nice nomenclature system based on C3 and everything. But my question is, didn't we see patients with only C3 20 years ago? Because we've been doing immunofluorescence forever.
we must have. But actually, I think the hepatitis C associated diseases really just dominated this area. So we were only thinking about hepatitis C related GNs, right, which was mostly the MPGNs. And once that got
Disappeared.
treated,
Let's
cured,
use the word
essentially.
cure, right?
Right, at least in the US, right? And so now we really don't think about hepatitis C associated
And some of these other subtypes start to
MPGN.
emerge.
Exactly. And so now we can focus the attention on C3 glomerulopathy. I think we've created these boxes, right? These buckets, diagnostic buckets I like to think of, and we try to cram our patients into these different buckets. And complement and C3 glomerulopathy, we're now recognizing probably is having a role in many different renal diseases. And so then these buckets that we had, right, these boxes are too rigid. And now we're struggling with how do we break down those walls and those barriers so that we can accurately describe what's going on in our patients.